And hello, everyone. Welcome to today's webinar titled Millon Adolescent Clinical Inventory 2, Challenges in Assessing Complex Teens, which is the third in a series. The first webinar was an introduction to the MACI-II, and it provided a detailed overview of this new version of the instrument. The second webinar focused on how the MACI-II can be helpful when working with adolescents who present with internalizing or externalizing problems. While it's important to measure and identify such clinical issues, the MACI-II takes us beyond this level of assessment and provides insights into the context, personality-wise, in which those internalizing and externalizing problems are occurring. Today's webinar is going to build upon the previous ones by reviewing key features and significant advances of the MACI-II, including a close look at the test's normative sample through a comparison of subjects who were seen in juvenile justice correction settings during the instrument standardization phase and matched controls from the overall normative sample. The data will be presented and appear to be consistent with an impressive literature base on adolescent offenders, trauma, and delinquency. An illustrative case at the end will reflect and reinforce the major points of today's talk. MACI and Millon are registered trademarks of Dicandrian Inc., and the MACI-II is published and distributed exclusively by NCS Pearson Inc. I'm Robert Tringone, a co-author of the MACI-II. And I tend to be an over-incorporative type. So we have a lot of material to cover today. So let's get going. I'm not sure how many of you have listened to the previous webinars. So let's review a few points on the next 3 slides so everyone has some common knowledge about the instrument. The MACI-II is a self-report inventory that consists of 160 true-false items and 24 clinical scales. It has been designed to assess personality characteristics according to Dr. Millon's theory, as well as clinical syndromes in adolescents, 13 to 18 years old, who are undergoing psychological assessment and/or treatment. The MACI-II was normed on adolescent clinical population, and it should not be administered to those who are not undergoing an evaluation or receiving treatment. The MACI-II is intended to be administered at the beginning of treatment. However, it can also serve as an outcome measure. Let's review some of the similarities between the MACI and MACI-II. From the outset of the revision process, it was decided that the MACI-II would remain the same length as its predecessor, since its brevity, while assessing many clinical matters, is one of its strengths. Adolescents are typically able to complete the inventory in less than 30 minutes. Dr. Millon's personality theory, with its 3 polarities, 8 clinical domains, and scores of personality subtypes, provides guidance and direction in understanding a person, who they are, what factors have influenced who they are, what are their strengths and vulnerabilities, and what tendencies might perpetuate their pattern. His theory helps us make sense of what we see or hear clinically and alerts us to what we might not have seen or heard yet, especially when the inventory is administered at the very beginning of treatment. Both tests present the primary clinical scales in 3 sections: personality patterns, express concerns, and clinical syndromes. The MACI-II has 11 personality pattern scales, and elevations on these central scales of the instrument provide insights into an adolescent's developing personality type, which in turn provides the context within which all other clinical scales are interpreted. 4 express concern scales assess common adolescent areas of concern, And there are 9 clinical syndrome scales, of which 3 are new: post-traumatic stress, disrupted mood dysregulation disorder, and reality distortions. Each of the 11 personality pattern scales has 3 Grossman facet scales, which reflect the most salient traits that are associated with each personality type. The facets correspond to key clinical domains that are typically assessed, and clinicians may choose to generate either interpretive or profile reports. The interpretive reports have been updated, include gender-neutral narrative versions, and diagnostic considerations are aligned with DSM-5 categories. There are some significant changes between the 2 instruments. The MACI-II was developed with a normative sample that exceeded 1,100 subjects, 50.5% female and 49.5% male. A new scoring system was implemented. Items are scored on a 0, 1, 2 basis. Prototypal items, those items written specifically for its home scale, when endorsed, add 2 raw score points to the home scale. An item is labeled a subsidiary item to other scales based on statistical and content analyses. And if endorsed in a specific direction, it adds 1 raw score point to the other scales. Simplifying the scoring system from the MACI-I dramatically reduced the amount of item overlap between scales. So as a result, scale co-elevations are not the result of item overlap. They stand on their own. Additionally, we have eliminated program-generated base rate score adjustments. One of the primary reasons to drop the former modifying indices was that adjustments were being made without knowing the context of a test taker's endorsements. There are 3 new validity indicators. The first one, invalidity, consists of 2 straightforward items that essentially ask the subject if they're answering truthfully. The second indicator, inconsistency, is a more sophisticated measure of detecting possible random response sets. And the third indicator, response negativity, provides a means for the clinician to determine whether a subject may have potentially under or over-reported their problems. Clinicians will determine the possible explanations for a specific score, taking into account what they know about the subject, their history, their purpose for the administration of the test, and the setting, among other factors. Not to be overlooked among these significant changes is a reworking of the noteworthy responses section. 3 bipolar spectrum items have been added, as well as 3 ventrally prone items that inquire whether a subject has thoughts, motivations, and plans to exact revenge on others. Here's a slide regarding normative sample demographics. So let's talk a minute about the MACI-II normative sample, which consists of more than 570 females and 560 males, and there are 2 important changes. This first slide illustrates the changes in the area of race ethnicity. You can see that the MACI-II sample is more racially diverse than its predecessor and more representative of the population of adolescents seen in clinical settings at this time. This other slide shows that the MACI-II normative sample was collected from many types of settings, with a dramatic shift from residential and hospital settings, noted on the right side of the screen, to a majority now gathered in outpatient settings, see the left side of the screen. At the same time, though, I want to guide you right actually to the middle of the screen. where you'll see that 10% of the MACI-II sample that was collected in juvenile justice correction settings. Dr. Catherine Presnell, my research director at Pearson, compiled, analyzed, and explained compelling results to me that I'm going to present to you. First, though, I'm going to set the stage with a targeted review of an active and evolving literature base on juvenile offenders. I'll give you a moment to read through this as I provide you with some information of the literature review that I did. Adolescents who are involved with the juvenile justice system have very high rates of trauma exposure, which typically starts at a young age, occurs in multiple settings, and aggregates over time. These high rates of trauma exposure have been found in juvenile offenders across countries, cultures, genders, and actually levels within the juvenile justice system. Studies over the past 25 years have empirically demonstrated links between trauma exposure, trauma symptoms, PTSD, comorbid internalizing and externalizing disorders, and delinquency. It so happens that the MACI-II has scales that assess these very constructs. Two research paths have been pursued in regard to proving high rates of trauma exposure in this population within the juvenile justice system. One path has involved documenting and tallying adverse childhood experiences, or ACEs. 10 ACEs serve as particular risk factors to note: emotional abuse, physical abuse, sexual abuse, emotional neglect, physical neglect, parental separation or divorce, household substance abuse, household mental illness, family violence, and incarceration of a household member. One study of severe juvenile offenders based in Florida found that female offenders had higher prevalence rates than males for all 10 ACE categories, while the top 3 categories were the same for both genders. Family violence at greater than 80%, parental separation or divorce greater than 75%, and incarceration of a family member greater than equal to 65%. And as you might have deduced already, ACEs do not occur in isolation. 90% of the subjects reported at least 2 ACEs, and almost 1/3 of the subjects reported 5 or more. These risk factors have strong associations with rates of substance abuse, school dropout, teenage pregnancy, and joblessness, among other negative outcomes. In regard to the second point here on the slide, another research path has focused on how those same traumatic experiences are associated with high rates of mental health conditions, including PTSD, among juvenile offenders. In early comparison studies of male and female juvenile offenders in California, researchers found that 32% of the male cohort met all criteria for a PTSD diagnosis, and another 20% met partial criteria. While among the female cohort, 65% met PTSD criteria at some point in their lives, 49% of the female cohort met PTSD criteria during their incarceration, and another 12% met partial criteria. These staggering numbers have been reported again and again. Researchers tapping into the National Child Traumatic Stress Network's core dataset reported on a large sample of adolescents who had been seen for trauma-focused treatment prior to having contact with the juvenile justice system. The average number of trauma types experienced by these adolescents was 4.9, with 90% of the sample experiencing multiple trauma types. They reported high levels of PTSD symptoms, with 24% falling within the clinical range for PTSD. And the more I thought about something from this study, the more unsettling it became. It's as if there was an incubation period for the impact of the trauma to be fully realized, with 1/3 of the sample having had their first exposure before their first birthday, and another 28% between ages 1 and 5. In regard to the third point here, gender differences and sexual abuse, the study with NCTSN's core dataset found sexual maltreatment/abuse and sexual assault rate were 2 and 4 times higher respectively for females than males. And in those California-based companion studies I noted just before, females were found to be more than 3 times more likely to have been a survivor of physical or sexual abuse. In a sample from a juvenile justice center in Illinois, female offenders were more than 12 times more likely than male offenders to have been, quote, forced to do something sexual that they did not want to do. And in an Ohio-based sample, females reported rates of sexual abuse that were 13 times higher than males. From a different data point perspective, studies of female offenders in Australia and Japan found that 50% and 55% of the subjects, respectively, were survivors of sexual abuse. These numbers are very sobering, and given time constraints, it's a hard shift to the next 4 slides, through which I'll share some of the data we can report between the subjects seen in juvenile justice corrections, and I'll now say JJC settings, and matched controls. We have 113 subjects in each group, 64 females and 49 males. 65 subjects are in the younger 13 to 15-year-old group, and 48 subjects are in the older 16 to 18-year-old group. Now, when we're looking at MACI-II profiles and we're comparing JJC subjects to matched controls, we want to know if the 2 samples differ on the validity measures first. Will we obtain reliable and valid results? This slide provides some information for the inconsistency scale, which consists of 31 semantically similar item response pairs. The scale was developed to identify discrepant responses to item pairs that are usually answered in the same direction, both true or both false. A raw score of 1 is tallied when the responses to an item pair do not match. Typically, you will see a raw score of 2 or 3. So back to the question, do the samples differ? Overall, the answer is no. They are not different, as seen in the first line. Now, you can see the asterisk for the 16 to 18-year-old groups. Yet this appears to be one of those instances in which statistical significance is detected. However, it is not clinically meaningful because the means for the 2 groups are actually less than 3. And the cutoff at which we begin to question the validity of a MACI-II profile with the inconsistency scale is 7. Next up in regard to profile validity is the response negativity scale. This scale consists of 42 items, essentially 2/3 that are negative in content and 1/3 that are positive in content. And the scale was constructed so that high scores represent an undifferentiated pattern of negative responses across the items, and low scores vice versa. At first, you might think the JJC sample would underreport, but this is not borne out. no statistically significant differences were found between the samples according to age or gender. Right now, what you are looking at are raw scores for the response negativity scale. The response negativity scale, though, converts raw scores to percentile ranks, and it is interpreted according to those percentile ranks. So if we look at these raw score means that we have on the slide, when they are rounded up, they all translate into percentile ranks that fall between 35 and 65. Or in other words, they all fall within the middle third of the scale. Now, when we're working with subjects who may be within the JJC setting, we do want to take a look at what differences we might find on the delinquent predisposition scale, which often is associated with those who are having legal problems of some sort. So this slide presents the base rate scores on the MACI-II's delinquent predisposition scale. And since we're comparing those JJC subjects to matched controls from other clinical settings, we actually expect statistically significant differences between the samples to be found. The asterisks indicate that this is true for all four groups: younger female to female, younger male to male, as well as older female to female, and older male to male. A curious finding, though, is that the JJC females overall scored higher than the JJC males. The difference is significant when the two female JJC groups are combined and compared to the two male JJC groups. However, the statistical significance is not met when they are separated out. Another way to consider the data points that we have here is that 80% of the JJC females and more than 55% of the JJC males attain base rate scores of 75 and above on this delinquent predisposition scale, while less than 10% of the female matched controls and 30% of the male matched controls attained such elevated scores. On the MACI-II, the significance of the base rate score equal to and above 75 is that it represents the presence of a construct. Another significant scale that we want to take a look at, given the form and format for today's webinar, is what's happening when we compare these two groups on the post-traumatic stress scale. So this scale was created to identify trauma-related symptoms because a high percentage of adolescents seeking therapeutic evaluation or treatment report a trauma history. And remember that this is a new scale to the MACI-II. Consistent with what I reviewed before, this slide indicates females in JJC settings reported more trauma symptoms than males from the same settings, as well as females in the 13 to 15-year-old JJC group reporting more trauma symptoms than the female matched controls in the same age group. The females in the older JJC group continue to report a high number of trauma symptoms. However, the difference between them and the older female matched controls is less because subjects in the latter group reported more symptoms in comparison to the younger female matched controls. And just like with the delinquent predisposition scale, another way to consider the information I'm providing to you is that 40% of the JJC females attain base rate scores of 75 and above on the post-traumatic stress scale. That was 40% of the JJC females, while less than 20% of the female matched controls attained such elevated scores. Again, the significance of a base rate score equal to and above 75 is that it represents the presence of a construct. And in this instance, that's trauma-related symptoms. Moving on, This slide is titled Structure of a Clinical Science, Personology. The Millon inventories are well known and can provide clinically valuable and distinctive insights into a person. Whenever I have the opportunity, though, I like to point out that the instruments are actually one part of a comprehensive system. Dr. Millon outlined 4 central and necessary components of a clinical science, and he was trying to compare psychology to other hard sciences. The first component, theory, provides a foundation and a model through which one can derive and explain the clinical constructs that one observes. And those constructs are personality types for adolescents and personality disorders for adults. Taxonomy, the second component, focuses on the need for a standardized system of classification that assesses these constructs across the same domains, and that a distinguishing feature within each domain for each personality type or disorder has been identified that can help differentiate them from each other. Instrumentation, the third component, represents how the constructs identified by the theory are operationalized and measured. And the final component, interventions, relates to the treatment strategies that clinicians can utilize to help. It follows that treatment interventions can be formulated in regard to the central polarities from the first component, the clinical domains that have been identified from the second, and what are called self-perpetuating processes that all personality patterns possess. Each personality type engages in certain ways of behaving, thinking, feeling, and relating that set up situations and interactions that are believed to reinforce them. Here's a quick look at Dr. Millon's evolutionary theory and the 3 polarities. Dr. Millon's theory was initially a biosocial learning model, which over a span of 40 years progressed to an evolutionary model. At each level, the same 3 polarities, pleasure-pain, passive-active, and self-other, while conceptually modified between the biosocial learning model and the evolutionary model, are combined and configured to identify, define, and explain the personality patterns that are measured by each of the Millon inventories. In some personalities, there is an imbalance to being strong or weak on one or more of these polarities, while other personalities are theorized to have conflicts within one or more of these polarities. Listeners who are interested in learning more about these foundational polarities are encouraged to read Dr. Millon's Disorders of Personality texts. I've made reference a few times to the domains, and having studied and collaborated with Dr. Millon for more than 25 years, it is my belief that his personality theory is the most integrative and comprehensive one we have, because it encompasses many schools of thought and has us consider multiple data levels, including behavioral, phenomenological, psychoanalytic, and biological. This slide lists the 8 clinical domains that are outlined in the theory. The MACI-II Grossman facet scales are based on these domains. Now, some of these facets are more prevalent than others, given the instrument's self-report format and its item pool. You have to have enough items in order to create a scale. I encourage you to learn more about these domains and Dr. Millon's theory by reading his Disorders of Personality texts, so you can see for yourself and make your own decisions. We're moving our way toward, now that we have all this information, we're going to make our way toward an illustrative case that's going to try and pull so many of these ideas together. So there is a recommended set of interpretive steps for you to take when you're going to interpret a MACI-II profile. Step 1 involves starting with basic demographic and background information. What do we know about the subject? Their age, because we have a younger and older group to compare to, as well as developmental norms to consider. Their family system, peer relations, school performance, level of functioning in various settings. What are the actual presenting problems, etc. While steps 2 through 4 focus on the interpretation of a MACI-II profile, it is conducted systematically, starting with step 2 here, which would be to take a look at the validity scales. We also want to gauge the overall severity of the profile, which is done in several ways that I'll review in a moment. Step 3 involves us interpreting the 3 sections of clinical scales, incorporating information found on those Grossman facet scales that I've referred to, and checking the noteworthy responses section, which may identify needs to explore other areas with further inquiry. And finally, in step 4, when we have those opportunities, and ideally we would like to be able to do this, because we really do not want the MACI-II to stand on its own, we do like to see it integrated with other information. We would like to integrate MACI-II results with clinical information that's gathered from other sources. So in quick review, here are the 3 new MACI-II validity indicators. I described each of them before, and we'll review them during our illustrative case. Here are the list of the 11 MACI-II personality pattern scales and their DSM counterparts. Now on this slide, you're going to notice some differences. Several DSM personality disorders were included in previous DSM editions, including appendices, but they are not in DSM-5. Nevertheless, these constructs continue to be assessed with the MACI-II, and for that matter, with the MCMI-4. Because of their positions within Dr. Millon's theoretical model, their clinical relevance from our perspective, and their empirical support during the MACI-II's developmental stages. The MACI-II does not offer personality disorder diagnoses. I want to be clear about that, and I'll state it again. The MACI-II does not offer personality disorder diagnoses. Instead, we focus on personality types, traits, and features that are highlighted for clinicians to consider. Here are the 4 express concern scales from the MACI-II. I like to consider them in pairs, and the first pair, consisting of the identity diffusion and self-evaluation scales, are self-focused, while the second pair, consisting of peer insecurity and family discord, are other-focused. Items for these scales prompt adolescents to respond according to how they see themselves in relation to others, as well as in comparison to their own expectations. And these are the 9 clinical syndrome scales. And just to make sure that all of us are on the same page, the MACI-II includes these 9 scales in order to assess acute and more transient clinical syndromes. We can see with scales DD and EE that anxiety and depression clearly needs to be covered by the instrument, and that the suicidal tendency scale, FF, is here in order to assess for ideation and risk. The binge eating pattern scale focuses on binge and overeating tendencies, as well as bulimic symptoms, while the substance abuse proneness scale inquires about alcohol and drug use. Those adolescents who are engaged in serious acting out behaviors may elevate on the delinquent predisposition scale, as we have seen, while long-standing and persistent problems with anger, frustration tolerance, and impulse control are measured with the disruptive mood dysregulation scale. The post-traumatic stress scale is focused on identifying trauma-related experiences and symptoms. while the reality distortion scale, a new addition to the MACI-II, will elevate when adolescents question their grip on reality, that they fear they are losing touch with reality, or they may report that they are hearing voices or having auditory hallucinations. Given all of that information, so we have a hopeful foundation to move forward with our case study. I'm going to provide you with some information, and then we're going to systematically go through how we would interpret such a profile. Today's illustrative case is about a 16-year-old female who lives with her mother, stepfather, and 2 half-siblings. Her birth parents were young when they married, and she was born a year later. It was not long after that parenting responsibilities and financial pressures started to impact an already strained relationship. Her birth father began drinking and staying away from home more often. Frequent arguments eventually culminated in an episode during which her father punched her mother multiple times, resulting in bruises to her body and face. Our subject was 4 years old when she and her mother left her father and moved in with her maternal grandparents. She settled into her new home life, started school, and made friends, and her father disappeared from her life. When our subject was 8 years old, her mother remarried, and they moved into her stepfather's home in another town. At this time, with her mother and stepfather working, and her grandparents too far away to provide daily after-school care, she was sent to a neighborhood sitter. Within a few months, she was telling her mother she did not want to go there anymore. Her mother and stepfather thought she was being difficult and kept sending her to where several years later, she revealed she had been sexually molested multiple times by the sitter's teenage son. This arrangement finally stopped when her mother became a stay-at-home mom to twins when our subject was 11 years old. While she was initially excited about the arrival of her twin sisters, over time she gradually began to resent the times her mother and stepfather doted on her twin sisters and expected her to care for them, especially when this interfered with spending time with friends. She started underperforming in school and spending more time away from home after school. Her mother and father did not like the friends she chose, suspected she was drinking or smoking, and gave her harsh consequences for any transgressions. Tensions in the home continued to escalate until the recent episode during which our subject forcefully pushed her mother into a kitchen counter, injuring her back. Her stepfather witnessed the episode, called police, and had her arrested. The MACI-II was administered as one part of a comprehensive evaluation to determine the most appropriate course of action. This illustrative case is set within the juvenile justice system, although it is probable that some listeners have encountered a similar story in other clinical settings. Looping back to earlier points, our subject was reported to have experienced many adverse childhood experiences, including sexual abuse, family violence, parental divorce, and household substance abuse. Let's see what her MACI-II profile tells us. So a quick scanning of her profile reveals that it is a complex profile. A total of 11 clinical scales have reached a level of clinical significance, with 5 scales reaching base rate scores of 85 and above, and another 6 scales have base rate scores that are 75 and above. Also, scale elevations have been found in all 3 sections. For us, we want to point to as the core among the personality pattern scales that the unruly and discontented are the highest personality pattern scale. From a slide a few back, the unruly is associated with an antisocial tendency, and discontented is a more negativistic personality style. And we do see a relative elevation on the borderline tendency scale, which itself is a severity gauge. If we jump down to the clinical syndrome scales, we're seeing that the most elevated scale among this scale set will be delinquent predisposition. Not unusual given that she is in a JJC setting. But I also want to point out that there is a relative elevation on the post-traumatic stress scale among the 5 that are elevated in that section. These are all things that we have to take a look at. So if we look at the profile, we want to know that it is valid. And I want you to look above the graphs. You will see that the invalidity score is 0, which is the expected value. And the inconsistency score is 5, which is a little on the high side, but still below the questionable cutoff score of 7. Some adolescents I have found are very discerning in their responses. And if you wished, you could check the item pairs with a subject in order to understand the reasoning behind their responses that did not match. Toward the right side above the profile, we have information regarding the response negativity scale, which places her at the 82nd percentile rank, which is elevated, but not an extremely high score. And recall that this scale assesses whether there is a broad range of problem areas that an adolescent has reported struggling with. And based on the clinical vignette, this score is not beyond expectations. I'm going to have us take a closer look at the personality pattern scale. In particular, we're going to focus on unruly and discontented, and then borderline tendency. We're going to focus on what we might refer to as an unruly discontented 6A, 8A 2-point code, and incorporate the moderate elevation on the borderline tendency scale, which I noted just before serves as a severity gauge. In this instance, the elevation on the borderline tendency scale with a base rate score of 80 indicates a moderate level of disturbance in her overall personality structure. The 6A, 8A profile is indicative of an adolescent who feels that others do not understand or appreciate her. Key challenges include that she engages in acting out behavior, tends to be moody and irritable, and is emotionally sensitive and reactive. The unruly scale represents the active, independent personality type, which is conceptualized to be strong on the active and self polarities. The elevation on this scale suggests that she values autonomy and that past experiences have taught her she cannot count on others to be supportive and protective of her. The discontented scale, which measures the active ambivalent type, highlights a strong sense of ambivalence toward others. She is strong on the active polarity and in conflict on the self-other polarity. She struggles with an intense conflict over underlying dependency needs that have not been consistently gratified, while harboring deep resentment and mistrust toward those who have disappointed her in the past. She anticipates further disillusion from future relationships with others and often acts in obstructive and passive-aggressive ways. This creates a vicious circle and self-fulfilling prophecy. Her moods and behaviors frustrate others, who in turn may act in similar ways toward her. It is probable that she's most susceptible to impulsive and volatile actions when she feels pressured, frustrated, or misunderstood. The elevation on the borderline tendency scale further suggests an unstable quality to her ways of behaving, thinking, and feeling, as well as to her sense of identity and sense of self. This may be reflective of a less secure personality foundation, which leaves her vulnerable to becoming overwhelmed and distressed, even when she faces ordinary, age-appropriate demands. These features can lead to more frequent and more intense challenges in her interactions with others. Now I'm going to do one of those quick shifts. So I want to take a step back for a moment. So I want to talk quickly about how common is the 6A, 8A profile among those who elevate on the delinquent predisposition scale. And what we have set here in this slide is among the normative sample, which is over 1,100, we've identified 212 subjects who elevated on the delinquent predisposition scale at a base rate score greater to or equal or greater to 85. And this therefore will extend beyond those who have been seen within juvenile justice correction settings. There are numbers that are quite notable here for two reasons. First, that 56% of those subjects had the unruly scale as their highest or second highest personality pattern scale. And you see that for 6A4, 4-6A, and so on, which leaves 44% who had other 2-point code combinations as their highest scales. Now, all these subjects are assumed to have engaged in some version of acting out behaviors, externalizing behaviors. And many were seen in JJC settings, yet their different underlying personality types, one, can provide valuable insights into the motivations for their actions. Two, have the potential to predict future behaviors and outcomes. And three, may help determine appropriate consequences and interventions. Now, a second point is that MACI-II profiles help differentiate between these 2-point codes. Even if someone has the same elevation, in this instance, let's say unruly 6A, depending on what the second high point code is, there will be a different interpretation. So for example, the unruly dramatizing type is typically outgoing, makes good first impressions, and often creates social facades. Driven by a need for excitement, which is coupled with difficulty delaying gratification, this type displays a willingness to take risks. Impulsive and short-sighted actions can lead to consequences, yet punishments tend to reinforce their rebellious and defiant tendencies. Now, let's take a look at the unruly forceful type, which is 6A, 6B. And let's contrast what I just described to now this description. The unruly forceful type projects a defiant and combative air, is belligerent and hostile toward others, and takes pride in appearing tough and strong. Issues around trust, power, and control are prominent, and these types have a desire to provoke fear in others and to intimidate them. This type typically lacks empathy and harbors deep-seated anger and resentment toward family members and authority figures. I wanted to take this step back with this slide because I believe this information reinforces the idea that we need to go beyond identifying that someone engages in an externalizing behavior pattern, and that there's so much more information to be gained when we focus in on what's the context personality-wise to these behaviors. But let's quickly shift gears and work toward finishing our case. So now we have the Grossman facet scales and how they are presented in a report. The 3 facet scales for the 3 highest personality pattern scales are presented in graph form, usually starting with the facet scales for the personality pattern scale with the highest base rate score to the 3rd highest base rate score. There is an exception, which is when the borderline tendency scale has a base rate score of 75 or above. And in those instances, like here, it is graphed first. The interpretive text for the facet scales, on the other hand, is generated for the 3 highest facet scales among those that are graphed. So in this instance, that would include the interpersonally irresponsible and acting out mechanisms from the unruly scale, and the expressively resentful facet scale from the discontented scale. Each facet scale for each personality pattern scale is anchored by at least one of that home scale's prototypal items. Additionally, a prototypal item is included in only one facet scale for its home scale. There's no double dipping among the 3 facet scales for a home scale. However, prototypal items from one personality pattern scale, let's say unruly, can be included in facet scales for other personality scales. And then let's say forceful or discontented. Any of the 33 facet scales that exceed a percentile rank of 75 are interpretable. In this case, I won't interpret the more than 20 facet scales that meet that criterion. If you have encountered an instance like this, I suggest you review the elevated facet scales for the 3 highest scales. And here again, we have unruly, discontented, and borderline tendency, because they'll further enhance your interpretation of those home scales. In regard to the remaining elevated facet scales, I suggest you organize them according to the clinical domains. In the mood temperament domain, for example, the forceful, temperamentally hostile, and the dramatizing, temperamentally fickle facet scales are elevated and seem consistent with the borderline tendency, temperamentally labile facet scale. Another example is the interpersonal conduct domain, within which our subject has significant challenges. There are 5 elevated facet scales in this domain. I'll point out the borderline tendency paradoxical facet scale is new, and an elevation here suggests that one's actions are often antithetical to attaining one's goals in the interpersonal sphere. Moving on to the express concern section, we see that our subject has identified several areas of concern. It's clear that she sees significant problems within her family. Tensions run high, and she feels a lack of support and understanding. Turning to the self-oriented pair, we see that she seems distressed over an ongoing struggle to create a stable sense of identity. In comparison to her peers, she feels much less sure of herself and her future plans or goals. Among the clinical syndrome scales, the elevations really illustrate our story and provide insight into the above average percentile rank on the response negativity scale. This section of the interpretive report would actually start with the post-traumatic stress scale. Although it is not the highest among this scale set, when the post-traumatic stress scale exceeds a base rate score of 85, we want to alert clinicians to the presence of symptoms consistent with exposure to trauma. Additionally, given our subject's underlying impulsiveness and moodiness, especially in regard to anger, irritability, and frustration, there may be a tendency to lash out at others, potentially displacing emotions onto those who are closest. One of the noteworthy response sections is labeled traumatic experiences, and our subject endorsed 3 out of 4 items. Also, she endorsed 1 out of 3 ventrally prone items, the one that might be related to the suspect who sexually abused her. From there, any scales with base rate scores greater than or equal to 75 are interpreted in order from highest to lowest. That would involve the delinquent predisposition scale. We would be looking at the depressive affect and disruptive mood dysregulation scales, given some struggles with depressive symptoms and long-standing issues with anger discontrol. And finally, you will have to check the substance abuse proneness scale. Very high base rate scores, let's say 85 and above, will be indicative of mixed substance use, likely including alcohol and marijuana. A mid-range elevation like we have here could be a sign that she uses either alcohol or marijuana. All this information then leads us to diagnostic considerations for the clinician to think about. But here's the caveat. Clinicians determine the final diagnoses. The personality pattern section will take the highest scale, in this instance, the unruly scale, with its base rate score above 85, and identify it as a type, followed by discontented traits and forceful features. But you'll also see the note regarding the borderline tendency scale elevation. Many of the clinical syndromes and express concern scales translate into diagnostic considerations also. The delinquent predisposition scale triggers the conduct disorder and oppositional defiant disorder diagnosis to be considered. The elevation on the disruptive mood dysregulation scale, in turn, is related to the intermittent explosive disorder or disruptive mood dysregulation disorder, diagnostic considerations. Adjustment disorder with depressed mood is depressed affect, and the parent-child relational problem is related to the elevation on the family discourse scale. Now, after all of this, the final section in this interpretive report is that you have a treatment guide that exemplifies the fourth component of Dr. Millon's model for a clinical science. These guides center around the adolescent's personality type or subtype and provide information regarding early challenges to establishing rapport, address underlying polarity configurations, outline treatment targets according to the most salient clinical domains, and suggest ways to potentially alter the repetition and trajectory of the identified issues. Information from the report could assist in some decision-making also. For example, if you were the evaluator in this case, would you recommend that she stay within the JJC system or transfer her to the mental health system? Would you emphasize individual or family treatment? What about group treatment, given she has issues with anger and she is substance involved? These guides have a more positive and aspirational tone also. Working together, we can make a difference in an adolescent and his or her family. We made it through. I thought there was a lot of information to cover. If you have questions or concerns, you can certainly reach out to Pearson for support, and here is a way to reach out to them. And I also want to say thank you so much for listening. I hope the webinar has been informative and helpful to you, and maybe I've left a moment or two for any questions to cover. Again, thank you so much for listening.
Thank you, Robert, Dr. Tringone. We do have a couple of quick questions that I thought the group might like to hear your response to. First, Sander asks, do you see value in interpreting very low scores on the MACI-II?
Okay, that is an excellent question. I want to make sure we cover things, but I will look at, like in the express concern scales, that when in this example, all the troubles were in the family area, but that peer insecurity was not elevated, so that I would potentially consider that a strength. I know that she did not engage in suicidal, non-suicidal self-injury and so forth, so there were some positive things there as well. Among the personality pattern scales, it depends, but we usually focus on the scale elevations as the most important ones to interpret. I'll take into account, though, the overall profile. Again, if borderline tendency scale is not elevated, that could be taken as a positive sign that things have not reached a certain level of moderate or potentially even severe developing personality pathology. Good question.
Very, very good. Thanks, Robert. One more, just while we're just at time here, but Asher asks an interesting question. Will an interpretive manual like McCann's text for the original MACI be published soon to help with a deeper interpretation? Are you aware of anything that someone may be writing and crafting at this time?
I am not aware of that, but I would direct you to Dr. Millon's Disorders of Personality texts. And you will see, especially the most recent one in 2011, in which there are sections related to child and adolescent conditions that may be associated with different personality styles and types. And it is a longer continuum, more of a dimensional model, so that if you are looking for information in terms of how to interpret, if you do not get the interpretive reports, that I think would be your best resource at this point in time.
Very good, Robert. Well, I think that's all we have time for. Any questions that are still remaining in the Q&A, we will try to take care of offline. Thank you very much, Dr. Tringone, for a wonderful presentation, and thank you for all of our attendees. And we will hopefully talk again soon. Thanks very much,
everyone.